It's with great pleasure that I now introduce Natalie Taylor, Associate Professor, Director of Research at the University of New South Wales. And it's wonderful to have Natalie's IMPSI, see, I can be cool, IMPSI experience. Yeah, thank you. I'm being cool. And in our Hep C world, it's really enriching our work. So thank you very much, Natalie.
Thanks, Jackie. It's a real privilege to have you chair this session. Quick shout out to Jason, Guillaume, Andrea Torres-Robles and Maria Gonzalez, who contributed to the work I'm going to talk about today. And also really just to say that I am mostly a methods expert in implementation science, or IMPSI. And so apologies if I make any mistakes with the terminology today. Let's see. Okay, so you can call me Nat. There's some information about me on there. And the group that I lead is called I2I, or Implementation to Impact. And that's our philosophy. Really the work that we do is to study and support the translation of evidence into practice. So really love supporting healthcare professionals in their work and trying to understand all of the magical things that they do and see whether or not we can identify patterns behind the success that they create every day and spread it around so that everybody else can deliver better care to their patients. This is my team, my wonderful team. Andrea is on the top left there. Maria is, let me see, where is she? Somewhere in there as well. Somewhere in the middle with the ponytail, and they've done an incredible amount of work on what I'm going to talk to you about today, which is process mapping. So process mapping, and so this is going to be quite a methodological talk with a Hep C bent. I'm hoping that you're going to learn some new things to be able to take away and apply in your own work. So process mapping is a visual representation of the individual steps, decision points, task owners, and timelines. And everybody's probably been involved in some way, shape, or form in doing a process map as part of their research work or healthcare professional work. There are lots of different types, so you can have sequential flow maps like linear sequences and steps in a process, hierarchical task analysis where you have nested levels of tasks and subtasks, patient journeys, their experiences, emotions, interactions as they navigate the system, and value stream mapping in terms of the flow of materials, information, and processes needed to deliver a service or product. And with all of the kind of information that we can glean from process mapping, we can actually combine this with what we need to understand about how to change behaviour when we're thinking about improving a practice or implementing something new. And this is the combination. So we've published on a few papers where we've started to use process mapping and implementation science together so that we can really combine that understanding of how processes and systems work, the things that people do in those systems and processes, but also where exactly barriers, facilitators, and strategies might best fit. So process mapping can be used when we think about behaviour change in implementation science to identify contextual and individual factors influencing implementation. In implementation science, we develop, as Guillaume mentioned, evidence-informed implementation strategies. We evaluate implementation outcomes and we facilitate adaptation without compromising the effectiveness of the intervention. And if we combine this with behavioural analysis through process mapping, we can understand more about the who, when, what, and where things happen across this process. And this helps us to provide a clear understanding of complex processes, so we can really unpick work as imagined versus work as done. We can identify target behaviours for change or adaptable intervention components, visualise integration of interventions into existing systems, and identify opportunities to streamline and increase efficiency. And if we look at these two sets of things together, we can actually start to marry up where there are individual drivers of change that happen at different parts of the process so that we can really start to target the kinds of strategies that we need at different steps in the process rather than kind of throwing the kitchen sink in to try and fix all the problems. So we do in-person process mapping. So some of you may have been involved in that in the past. Nice whiteboards and markers, a few post-it notes. And during COVID, we were doing this quite a bit with a lot of healthcare professional teams, and then we had to switch to more of an online format. Where we were able to develop methods and skills to be able to deliver process mapping exercises online and really start to understand from individuals or groups of people in an online setting what their processes looked like and create these visual maps in real time with people on the screen. So why do we want to do mixed methods process mapping? Well, we can have a bunch of inputs. We can have interviews and focus groups where people actually talk us through their experience of the flow of the patients that they take through the system and the different tasks and interactions that they have through that process and with other healthcare professionals within their own service or site or across different sites and settings. And we can also incorporate really powerful audit data into those process maps so that we can start to understand a real holistic picture about where gaps may fall and also some of the experiences that healthcare professionals are having around those gaps. So we do a lot of stakeholder engagement in that process, and then some of the outputs can be target behaviours for change in line with the audit data that we collect, an understanding of barriers and facilitators that exist at different points in the process, a way to be able to develop strategies from an intuitive tacit knowledge perspective from healthcare professionals or through a combination of evidence-driven strategies. We can obviously think about how to improve processes, where we might be able to streamline things better, or where we might even be able to improve an intervention as a result of understanding exactly how a process works and how an intervention might best fit. And so across 3 core phases of implementation, we can use process mapping. So it's a really great tool to be able to engage your stakeholders. You can go to them with a draft on a piece of paper with a basic marker pen and really just start to ask them to walk you through the process. It's sometimes a lot easier to engage people with a visual. Identify areas for change. So in implementation science, we're often looking for the gap or the problem that we might be trying to fix. And then through implementation science as well, we can use process mapping to identify determinants and strategies. And we've used these methods in point-of-care testing, so through community sites in the National Point-of-Care Hep C programme, and you can see the aims, inputs and outputs of that programme there, and that's the one I'll go through today. We've also used it in the cancer genomic setting to co-design a new model of care using interviews, meetings, audit data, understanding existing processes, identifying barriers and facilitators. In a childhood cancer survivorship intervention where we were aiming to integrate a new model of care, and then also in a clinical genetics project around Lynch syndrome and really trying to improve referral pathways there. My button's working. So in terms of optimization of the point of care testing process for Hep C, the methods that we used were focus group, process maps, and implementation factors, where we presented initial maps to discuss gaps, target behaviours for change, and variations to the process. And we used interview questions guided by the CIFA that Guillaume mentioned earlier on, with 40 providers from 19 community sites across New South Wales, Queensland, Canberra, and WA in Australia. We've refined those process maps so that we ended up, I think we've got 17 there, but it might be 19 now, trying to identify the commonalities and variations. We identified barriers and enablers using the CIFA framework so that we had a really standardised way of coding those barriers and enablers so that we can look to identify these patterns, problems or successes. Mapped audit data with existing process maps for clarity and impact of implementation factors, co-designed strategies in a workshop in Darwin in August 2024 with 48 health providers from sites across different states, And then we undertook some focus groups to further develop those strategies, and we're currently in the process of a strategy package development. And so when we were engaging the stakeholders, we obviously wanted to get the right people in the room. And so we were establishing partnerships between implementation researchers and stakeholders, creating and presenting an initial process map as a conversation starter, designing process mapping activity based on insights, and leveraging those partnerships to recruit further participants. And this was an initial map that we came up with, very basic, but it was something that really did start the conversation and got people talking, and then you really started to realise the different perspectives and experiences that people had in different settings in how they delivered their care. This was one of the final process maps in a particular site, based on their experience and existing practice. And then the next stage was to see the gaps and not just goals. So here we adapted process mapping methods to the context, and so sometimes we needed to go in a bit more simplified. Other times we were able to take in a bit more of complexity depending on the audience. We conducted more process mapping activities, identifying core components, gaps, variation and target behaviours, and we're really trying to look to do ongoing refinement so that we really did get those processes right. We incorporated meaningful audit data that aligns with the steps, and this was a really powerful part of the process. As soon as people start to see where the gaps are, you can see their eyes light up, and where they know that they can then make the meaningful improvements. So you don't need to read all these, but I think there's 17 or so maps there from the community settings. And so obviously here it was just, individual maps for every single site. That's what we had to start with. But we then wanted to identify commonalities and variations. And here I'm just going to give you a flavour of what we can do with this information. So I'm not going to go into too much of the detail, but just so that you can see the power of what we can achieve in terms of understanding commonalities and variations in terms of who does what, when and where. So if we look at 3 example process maps here, if you look in the yellow boxes, you can see that we've got commonalities in terms of the what, and in the green, we've got variations. So I'm going to look here because I can't see. I think my eyes are going as well as yours, Guillaume. So up in the box at the top there, we've got peer workers. On the middle, we've got nurses and GPs and peer workers again, all doing the same task in different sites. In some sites, you can see incentives were provided and not provided. And then in terms of follow-up, we've got phone calls, follow-ups at the general practice, follow-ups at the hospital clinic. So you can kind of see some variations there. So then you can kind of see, I think I've already talked about that, so you can kind of see variations where in terms of the what is happening, you can kind of see where these variations lie. Who's doing what and where they're doing it. Again, just shows you the power of these variations between sites, where these things are happening. And then if you add the audit data, we can really start to use these process maps per site to understand gaps, but also then to be able to compare these gaps between sites. So as an example, in this particular site, one of the outcomes that we found was there was 25% testing errors, and that there was 42% not initiating treatment. So then if we think about, we've established the process, we understand commonalities and variations between sites, we've got the audit data, we can really start to tackle problems. Now we can start to see, well, where there are similar problems across sites, we might be able to see what barriers they're facing, and if they're similar barriers, then we can start to generalize the strategies that we use to overcome them. And that's what this is all about. We're really trying to achieve efficiencies in the improvements that we're trying to make in a process. So if we fix together with real and usable solutions, this is where we take that tacit knowledge of the healthcare professionals and also the evidence-based strategies that are matched to barriers where we know these work in different settings to overcome the similar types of problems. We can really start to think about how we operationalise those strategies and then develop and evaluate intervention packages that can hopefully address similar problems across a number of sites. So undertook the focus groups and interviews, audit data, refined the maps, identified the barriers, co-designed the strategies in different workshops, and then we have this strategy package. And so now we can really start to use these process maps to understand exactly where the barriers and enablers are. So you'll see it's I'll zoom in a second, but really on the left-hand column boxes, we've got the CIFA constructs, so that we've really got this standardised approach to understanding our barriers and facilitators. And then on the right-hand side, we've got a description of those barriers and facilitators. So if I zoom in a bit and really pinpoint, we can see in that bottom side of the map, we've got 2 target behaviours for this particular site that we identified. One was around communicating communication of a positive test, and the other was around treatment initiation within 12 weeks. And so then we can see that there's 4 different barriers that actually align with these 2 target behaviours. So we can now start to drill in, and we don't have to design 20 different strategies to address loads and loads of different problems. We can actually just maybe design 1 or 2, because we know that these specific barriers are occurring at this point, and at this site, this is actually where the gap lies. So just as an example, in terms of preliminary development of strategies, which have been informed by findings from our focus groups and interviews and co-design workshops, if we look at results interpretation and communication on that top row there, the CIFA dimension, we've got that coded, and the barrier was lost to follow-up. The description was people aren't coming back after testing, or come back with a positive test result but are unsure of treatment initiation. And then underneath, we've got the outer setting, partnerships and connections, access to treatment, and HCV medication availability, and that lack of HCV medication after a participant is eligible to start treatment. And so the implementation strategies, which were triangulated with evidence and previous experience and theory, were to promote adaptability, so follow-up calls to encourage people to go to the office and communicate the results, and build a partnership, so create one-stop stations by building partnerships with pharmacies and pathology centres. And then obviously after that, there's a process of actually operationalising these strategies, so thinking about who's going to deliver them, how often they need to be delivered, what resources are going to be needed in order to make that strategy a reality and actually fill that gap. So next steps, so we've done all these bits, we've got our action plan, and now we're ready for trial design. So we're really starting to think about, we've done all of this work, do we want to test our whole package of strategies that we've designed, or do we want to think about how we tailor different implementation strategies to gaps in different sites, and also the extent to which there may be the impact of process mapping itself on seeing these visuals and the gaps in practice, to what extent do these actually start to influence behaviour change naturally? How can we assess that? So we've presented the mixed methods process mapping framework as applied to Hep C point of care testing. And this paper here has not only a description of some case studies where we've used this, including a Hep C case study, but also a bunch of tools so that people can actually lift this information, run an in-person session or an online session, and then also, according to these 3 kind of major implementation phases, tools to be able to follow exactly the instructions of what you would need to do to run a session like this. I think there's, maybe more training that could be needed, but I think this will hopefully give people a really good starting point on how to run this kind of exercise. Parting messages are really just that in doing all of this, we obviously, we really want to understand barriers and facilitators, but for me as an implementation scientist, doing this in a structured way and recording it in a way that's reliable and replicable means that when we understand what works, then we can translate that information to other people, and they can hopefully replicate it and get the same results if it's positive, and deliver really better care to their patients. Okay.